Hello, welcome to RAAONLINE. I am Dr. Vijayaraghavan. Today we are going to take a topic on hyperthyroidism. Hyperthyroidism is where there is an increased thyroid hormones in the body. Hyperthyroidism and thyrotoxicosis are used interchangeably. But then hyperthyroidism is a state of increased secretion of thyroid hormone. Whatever the causes, if there is increased thyroid hormone in the system, we call it hyperthyroidism. Thyrotoxicosis is reserved for a clinical syndrome of hyperthyroidism. So what is the difference? If the patient has a clinical manifestation of increased thyroid in the body, then you call it thyrotoxicosis. Patient may have no symptoms at all in spite of increased thyroid hormone in the body, then you call it hyperthyroidism. So hyperthyroidism is predominantly a biochemical state, whereas thyrotoxicosis is a clinical state. Now coming back to the types of hyperthyroidism. Now you classify the hyperthyroidism depending on the organ responsible for the disease. Obviously, when the primary disease is in the thyroid gland, you call it primary hyperthyroidism. There are ever so many diseases which can produce primary hyperthyroidism. For example, Graves' disease, toxic adenoma. It's an autonomous nodule in the thyroid gland producing increased amount of thyroid. Toxic multinodular goiter, otherwise called Plummer's disease. Functioning thyroid carcinoma with metastasis, very unusual. Drugs, iodine excess, classically we call it Joad-Besdorf phenomenon, where there is an increased thyroid production because of iodine excess. There is a group of diseases which produce a transient hyperthyroidism. That means a period of few months of increased thyroid production. Classically happens in inflammatory thyroid disease. We will look into it later. It can happen in radioactive ablation also. Now coming to secondary hyperthyroidism, any TSH secreting pituitary adenoma can produce hyperthyroidism. There is an entity called thyroid hormone resistance syndrome. Chronic gonadotrophin secreting tumors. You have to remember, gonadotrophins act like TSH. So any disease which increases the gonadotrophin, it could be a chorionic gonadotrophin and any other source of gonadotrophins, this can create a situation like hyperthyroidism. Gestational thyrotoxicosis. This is a beta-HCG acting as a thyroid stimulating hormone. Stroma ovari, where ovarian dermoid tumors can have thyroid tissue there, may secrete thyroid hormones and create a situation of hyperthyroidism. Now coming to pathophysiology. Thyroid hormone secretion depends on TSH releasing hormone, which is coming from hypothalamus. Now basically there is an increased production of T4 and T3 by the thyroid gland. As we said, in Graves' disease, Plummer's disease, toxic nodule or transient hypersecretion in thyroiditis or radioablation. Second issue is increased peripheral conversion from T4 to T3. You have to remember, T4 is a storage form and T3 is an active form. So if there is any reason for increased conversion from T4 to T3, there will be state of hyperthyroidism. Another important factor to remember is all the features that hyperthyroidism are classically because of hyperadrenaline state. Now, hyperthyroidism per se does not increase the serum adrenaline level, but thyroxine enhances the response of beta adrenaline receptor to the endogenous catecholamines. So even when the normal catecholamines are available is in the circulation, the response to that catecholamine is enhanced by increased thyroxine level. So any thyrotoxic symptoms will be classically like hyperadrenaline state. Now if you talk about differential diagnosis of hyperthyroidism, The first one is pheochromocytoma, a classical picture of hyperadrenaline state. And the second is anxiety neurosis, where again there is increased adrenaline state. Now coming to Graves' disease, this is a classical primary thyrotoxicosis caused by autoimmune disease. Autoimmune antibodies against TSH receptors causes stimulatory antibodies, and that increases the causes thyrotoxicosis. This antibody is variously called long-acting thyroid stimulator, thyroid stimulating immunoglobulins, thyroid stimulating antibodies, or TSH receptor antibodies. It is a stimulatory antibody against TSH receptor. Coming to the effect of thyroid hormone in the body. The fetal brain and fetal skeletal maturation depends on thyroid hormone. If you remember, hypothyroidism during fetal development leads to a condition called cretin. So, thyroid hormone is necessary for brain development and skeletal maturation. It increases the basic metabolic rate. Thyroid hormone has got inotropic and chronotropic effect on the heart. If you remember, inotropic effect is contractility, chronotropic effect is excitability. So, increase the thyroid in the body increases the heart rate and increases the stroke volume because of increased contraction. Increased heart rate and increased stroke volume leads to increased cardiac output. That's the baseline, because it increases the sensitivity of beta receptors to endogenous catecholamine. Thyroxine increases the gut motility. So, you can explain the reason for diarrhea in patients with hyperthyroidism. It increases the bone turnover leading to osteoporosis. It reduces the cholesterol level. So, even hypothyroidism, you get hypercholesterol status. It increases the gluconeogenesis, though it does not increase serum or blood sugar levels. Coming to clinical features of hyperthyroidism, younger patients often show more of a sympathetic activity like anxiety, hyperactivity, tremors. Older patients manifest more of a cardiovascular symptoms like dyspnea, atrial fibrillation, unexplained weight loss. Patients with Graves' disease often have more marked symptoms than patients with thyrotoxics of other causes. Ophthalmopathy, pretrivial myxedema, dermopathy specifically occurs only in Graves' disease. Now coming to the clinical features, nervousness, sleeplessness, anxiety, increased perspiration, all classical features of hyperadrenaline state, heat intolerance because basic metabolic rate is high and patient is always very warm, hyperactivity, palpitations obviously because of increased heart rate, loose stools because of intestinal motility, increased appetite, weight loss. This is a very classical combination that occurs only in hyperthyroidism. Oligomenorrhea, amenorrhea are also part of hyperthyroid syndrome. Hair loss is another clinical feature. Thyrotoxicosis is often associated with eye signs. It is predominantly seen in Graves' disease. Proptosis, lid lag, periorbital edema, conjunctival edema and injection, poor lid closure causing exposure keratitis, extraocular muscle dysfunction causing diplopia. These are the classical regular features which we normally see in primary hyperthyroidism. Coming to eye complications, smoking seems to increase the severity of the eye complications in thyrotoxicosis. TSH receptor antibody that is seen only in Graves' disease seem to be responsible for ophthalmopathy and pretibial myxedema. and it is not seen in other autoimmune thyroid disease, though there are signs of thyrotoxicosis. Now coming to clinical signs of hyperthyroidism, Darry-Lympl sign, that is upper lid retraction, Vijayaraghavan sign, eyelid fullness, Stellwag sign, that is infrequent blinking or incomplete blinking, Grove's sign, that is resistance to pulling down the retracted upper lid, Geoffroy's sign, absence of crease in the forehead on superior gaze, Mobius sign, poor convergence, Ballard sign, restriction of one or more extraocular muscles. This is responsible for diplopia. Now, ophthalmopathy can be graded. Grade 1 or class 1 is just a spasm of the upper eyelid. Grade 2 is periorbital edema and chemosis. Grade 3 is proptosis. Grade 4 is extraocular muscle involvement. 5 is corneal involvement with ulceration, often due to exposure keratitis. 6 is optic nerve involvement with loss of vision. Ultimately, optic nerve damage happens because of severe ophthalmopathy leading to blindness. Now, how do we investigate in a patient suspected to have hyperthyroidism? Obviously, the basic test is thyroid function test. Classically, the thyroid stimulating hormone, that is called TSH, is very low. T3, T4 are elevated. Now, as we said, in pregnancy, beta HCG acts like a TSH. So, in this early pregnancy, first half of pregnancy, TSH may be low, total T4 is elevated, but free T4 is normal. It is predominantly because of increased level of thyroid binding globulins in the circulation. So, the total T4 is elevated, free T4 is normal. Now, later pregnancy, when the beta HCG comes down, TSH comes back to normal. It was low in the pregnancy. Now, the beta HCG is gone, so you get a TSH is normal. So, the total T4 elevation continues and free T4 comes back to normal. Now, second important test is anti-thyroid antibodies. These are the tests which clinches the diagnosis of autoimmune thyroiditis. Now, LATs, long-acting thyroid stimulator or thyroid stimulating hormone receptor antibodies, estimation helps in clinching the diagnosis of Graves' disease. These antibodies, this particular antibody is not seen in any other autoimmune disease. It is predominantly and only seen in Graves' disease. Anti-thyroid peroxidase antibodies. These are seen in all types of autoimmune thyroiditis, only to show that there is a destruction of thyroid follicles due to autoimmune disease. Similarly, destruction of follicles lead to thyroglobulin entering the circulation, leading to anti-thyroglobulin antibody production. So, all these antibodies are absent in Plummer disease and in toxic nodule. If you remember, the Plummer's disease is that thyrotoxicosis established over multinodular goiter. So, the disease process itself is different. So, though they have hyperthyroidism, antibodies are absent to show they are not part of autoimmune disease. Similarly, a toxic nodule, a thyroid adenoma, hyperfunctioning state does produce hyperthyroidism, but it has no anti-thyroid antibody state. Now, treatment. How do we treat patients with thyrotoxicosis? Now, the thyrotoxicosis treatment, medical treatment, may be the only treatment that is necessary, or it may be the treatment to bring the patient for a euthyroid state before undertaking surgical procedure. Now, medical treatment is beta blockers. Rather, beta blockers will completely reverse the sensitivity of beta receptors so that all the cardiac, GI tract symptoms will revert back to normal. Only issue is beta blockers cannot be used in asthma. Now, calcium channel blockers can be used when beta blockers are contraindicated. They also bring down the cardiac implications of thyrotoxicosis. Now, beta blockers and calcium channel blockers have to be tapered when the thyroid functions returns to normal. As we said, autoimmune disease slowly destroys the thyroid gland. During the destruction, there is a transient period of hyperthyroidism where you need these beta blockers and calcium channel blockers. But when the destruction is nearly complete, patient goes into a new thyroid state and goes into a hypothyroid state. So you need to taper off, beware that thyroid function is slowly deteriorating. You have to stop the beta blockers and calcium channel blockers. Now coming to anti-thyroid medication. Now the basic disease is increased secretion of thyroxine. So if you can prevent the secretion of thyroxine, your thyrotoxicity is going to get reverted. Methimazole and propylthiouracil. These are the two major group of drugs which are useful in hyperthyroidism. Methimazole and propylthiouracil both prevent iodization of thyroxine. So thyroxine iodization is the first step in thyroxine secretion. So thyroxine secretion comes down. Advantage of propylthiouracil is it prevents the peripheral conversion of T4 to T3. If you remember, T3 is an active form. T4 is converted at the cellular level to T3 for the action of thyroxine. So propylthiouracil prevents this peripheral conversion. Another major drawback with methimazole is it cannot be used in pregnancy, though it is most potent and first line of choice for treatment for hyperthyroidism. So indication for propylthiouracil is pregnancy when thyroid storm, as it prevents the peripheral conversion acutely in an acute toxicity state. It will be very useful. Or if the patient cannot tolerate methimazole, you have to use propylthiouracil. Remember, T3 is nearly 20 to 100 times more potent than T4. So if you propylthiouracil brings down the T3 level at the peripheral level, toxic symptoms are likely to get under control faster. Now, what are the side effects of antithyroid drugs? The major problem with methimazole is agranulocytosis. Aplastic anemia, hepatitis, polyarthritis, lupus-like vasculitis are also seen. Now, this agranulocytosis can be life-threatening because it makes the patient prone for infections. Luckily, the agranulocytosis is reversible by stopping the drug. You can prevent agranulocytosis by administering granulocyte colony stimulating factor. Now coming to propylthiouracil, hepatotoxicity is a major issue with that. So patient on propylthiouracil need to have liver function tests regularly monitored to keep an eye on hepatotoxicity. Now coming to other drugs that are used in hyperthyroidism. Lugol's iodine preparation. This is a solution of potassium iodide and iodine. It is very useful in acute thyrotoxic situation. It prevents iodine trapping, iodization of tyrosine and thyroxine release. It reduces the size of the gland and by reducing the vascularity. So in acute situation where you need to block it urgently, Lugol's iodine seems to be the drug of choice because it is very effective, very fast, but the suppression is temporary. Most threatening situation is Joad-Bestow effect. When it happens, especially when patients who are in iodine deficient areas where they are iodine starved, sudden supply of large doses of iodine can increase the thyrotoxicosis temporarily before it suppresses. So one should be aware that there may be a sudden worsening of the clinical situation of thyrotoxicosis if they are using Lugol's iodine. Coming to the other drug is cholestyramine. This is an anti-cholesterol drug which prevents the cholesterol absorption from the GI tract. Surprisingly, it prevents thyroxine reabsorption also from the GI tract. So, extension of this thought process, a patient who needs thyroxine replacement should not be taking cholestyramine. Now, thyroxine is secreted in the bile, reabsorbed in the GI tract like any other enterohepatic circulation, what happens in bilirubin and bile salt. So, cholestyramine, by preventing the reabsorption of thyroxine from the GI tract, reduces the serum thyroxine level. It is very useful in acute conditions. Second modality of treatment of thyrotoxicosis is radioactive iodine therapy. As we all know, thyrotrophs have got an affinity around 2500 times to iodine than any other cell in the body. So, any radioactive iodine which is taken up by the cell will cause localized radioactivity, causing destruction of thyrotrophs. Now, there are issues regarding the radioactive iodine therapy. Number one, it should not be used in pregnant women or lactating women for obvious reasons. The fetus or the breastfed babies will also be exposed to radioactive iodine because it may be secreted in the milk. It can cross the placenta and cause damage. Children less than 5 years should not get radioactive therapy for hyperthyroidism. Now, patient with ophthalmopathy will worsen if radioactive iodine therapy is used. The same thought process, if there is an acute destruction of the thyroid gland, there is a temporary increase in the output of thyroid hormone leading to acute thyrotoxic situation. Now, there is restriction on the dosage of radioactive iodine or radiation. In children 5 to 10 years of age, the radiation should be less than 10 microcurie. Children more than 10 years, a radiation dose of less than 150 microcurie per gram of tissue is been established. Now, what is the role of surgical treatment? Subtotal and total thyroidectomy. Ultimately, the source control is only removing the thyroid gland. Now, as we said from the beginning, predominantly hyperthyroidism is caused by autoimmune disease. So, surgical indication for hyperthyroid treatment of autoimmune disease is very minuscule. It is rarely indicated, rarely needed. So, when are the few situations where surgery is indicated in Graves' disease or autoimmune thyroiditis is when severe hyperthyroidism in children or in pregnant women or women non-compliant or intolerant to anti-thyroid pharmacotherapy. Large goiters and severe ophthalmopathy may be an indication for thyroidectomy. Patient refusing radioactive therapy, patient refusing radioactive iodine therapy may come into the bracket of surgical indication. Refractory amiodarone reduced hyperthyroidism, women who desires pregnancy in next 6 months, patient with unstable cardiac condition may be subjected to surgical treatment. The most important point in remembering surgical treatment is pre-op preparation of the patient, bringing them to euthyroid state. Any stress in a patient with hyperthyroidism can push them into thyrotoxic crisis. Now, to bring the patient to euthyroid state, obviously you need to use antithyroid drugs to reduce the output from the thyroid, beta blockers and or calcium channel blockers to keep the heart rate at 80 per minute. Lugol iodine 1 to 2 drops twice a day for 2 weeks, as we said, will reduce the size of the thyroid gland, reduces the output, reduces the vascularity of thyroid gland, which is very useful in surgical procedure. Coming to the last segment of ophthalmopathy. What is the treatment for ophthalmopathy? Most of the minor involvement, no specific treatment is necessary. If there is corneal involvement or corneal ulceration, or you just wear dark glasses, exposure keratitis can be treated with saline drops. Now, surgical treatment, or what are the other options for severe type of ophthalmopathy, like optic nerve compression, early vision changes? The options are high dose steroids, surgical decompression, radiation to the orbital area, monoclonal antibodies against insulin-like growth factor, which will reduce the exophthalmos and reduce the eye complications in ophthalmopathy. Now, before we close, other types of hyperthyroidism. In patients with Plummer's disease, only option treatment is surgical excision, subtotal thyroidectomy. As we said, it is a multinodular goiter with hyperthyroidism. So, surgery is definitely indicated. Subtotal thyroidectomy will clear the condition. Obviously, patient with a toxic nodule, which is a neoplastic disease of the thyroid, secreting large amount of thyroxine, surgical excision in the form of lobectomy or partial thyroidectomy, depending on the size of the tumor, will solve the problem. Pre-operative preparation and post-operative care is the same as for Graves' disease. Now, regarding follow-up, all patients in hyperthyroidism should be monitored for regressing thyroid function and slow progression to hypothyroidism. So, every patient with hyperthyroidism, not with multinodular goiter or toxic nodule, who are being treated medically for autoimmune thyroid disease, need to be regularly monitored to make sure they don't slip into hypothyroid state and continue their medication. There will be a stage where the patient is on antithyroid drug, passing on to a phase where they are in used thyroid state needing neither antithyroid or thyroxine replacement, slowly slipping into hypothyroid state where they need thyroid replacement. Thank you.